So here we're going to walk through cranial neuropathies in neuroanatomy. We're going to start with disorders of this somatomotor embryological set here, 3, 4, 6, 12, and 11. We're going to focus on 3, 4, and 6 in this first section. We're going to focus on brainstem aneurysms and cavernous sinus diseases as different causes of 3, 4, and 6 cranial neuropathies. And remember that these cranial nerves originate in midline and exit more medially. They're pure motor, except for 3, which has this autonomic component as well. Remember that 4 makes this immediate decussation, and so it exits on the opposite side of the brainstem, out laterally here, whereas the others originate in midline or close to midline and exit medially. These are the 6 cardinal positions of gaze. Note that cranial nerve 3 covers the majority of them. It covers upward eye movement as well as inner eye movement with medial rectus, and then inferior rectus as well. The other downward eye movement is produced by cranial nerve 4 through the superior oblique, and then 6, cranial nerve 6, innervates lateral movement via the lateral rectus. That's outward gaze. So let's walk through these different oculomotor dysmotilities. We'll start with cranial nerve 3. Cranial nerve 3 palsy. Think of the eye as down and out. That's a simple mnemonic for it. The eye is down here and it's rotated outward. And that's because up gaze is knocked out, and then this one portion of down gaze via the inferior rectus dysmotility is knocked out, but the superior oblique is still intact and the lateral rectus is still intact. And we can see that with this video here. So we see that the left eye here is essentially down and out. And then there's also some ptosis at rest. But here's the eye movements. This eye is the normal eye, and then this eye is the affected eye here. And you can watch that video again and again on the site. Cranial nerve 4 palsy, superior oblique is affected. So there's this eye elevation. And the mnemonic here is that the head tilts to the opposite side. That's a really important localizing feature. So why is this? So the right eye is the normal eye here. The left eye, the pupil is elevated. We can see, so there's this vertical diplopia. Both images from the different eyes are separated and their vertical axis. And then when the head, however, tilts, it tilts toward the opposite side of the side that's affected. Now the eyes are brought into alignment. So here there's vertical diplopia, here they're brought into alignment. Cranial nerve 6 palsy, the lateral rectus is affected. The eye is unable to rotate outward, so it's deviated inward here. And we bring up brain herniation, and that's because cranial nerve 6 is really vulnerable to stretch injury because it is affixed here. We see it in Dorello's canal. So when there's stretch here, the eye is affixed at the skull base here. That stretches on the nerve and affects it. So it's an early sign, a potential warning sign of brain herniation. Remember, we always talk about the uncus and uncal herniation affecting cranial nerve 3 as another sign of brain herniation. So let's talk about different brainstem aneurysms and the different oculomotor dysmotility they can cause. So PCOM aneurysm. This is the most common aneurysmal compression of cranial nerve 3. The posterior communicating artery affects cranial nerve 3 as it exits here. Then we also have the posterior cerebral artery and superior cerebellar arteries can affect right in here. And then AICA, the anterior inferior cerebellar artery, can affect cranial nerve 6 here. And then cavernous sinus thrombosis. It's really essential to know which cranial nerves exit through the cavernous sinus. We see that as 3, 4, the first 2 divisions of cranial nerve 5, and then cranial nerve 6. And then interestingly or importantly, cranial nerve 6 lies most adjacent to the internal carotid artery. So it's going to be affected first if there's aneurysmal compression or if there's an aneurysm of the carotid artery within the cavernous sinus, it's going to affect cranial nerve 6 first. So in cavernous sinus thrombosis, these are the cranial nerves that we're going to see that are affected. And then these are just some key causes: tumors, carotid cavernous fistula, and then infection as well, really important cause. A really important sign of infection is multiple different cranial neuropathies, especially if we can see them, see the pattern from the cavernous sinus itself. Internuclear ophthalmoplegias, this is really important for neuroanatomy localization. So this is the final common pathway. So the frontal eye field here, this anterior frontal eye field, innervates, comes down and innervates the contralateral cranial nerve 6 nucleus, the abducens nucleus. And then there are two components to it. There are the motor neurons, which go and innervate the lateral rectus on that side. And then there are interneurons, which cross, which decussate back to the original side here. And then they train up the medial longitudinal fasciculus here. They pass up the medial longitudinal fasciculus to innervate the oculomotor nucleus on that side, cranial nerve 3 on that side. So with this, you get eye deviation opposite to the side of innervation by innervating both the lateral rectus on the opposite side and the medial rectus on the ipsilateral side over there. So what can happen? So we'll go through the eye manifestations, and then we'll try and use those to interpret or intuit what has occurred. So in this situation, neither eye can move out this way. We'll call it to the right side here. So neither eye can move in that direction. So in an abducens nuclear injury on the right here, neither the right eye can move outward because the lateral rectus is affected, nor the left eye can move inward because the ocular motor nucleus isn't getting its innervation from the interneurons here. In this next one, the right eye is able to move outward, but the left eye is unable to move inward. And as another clue, just a reality, this eye will have nystagmus when this situation happens. So what occurs is there's an internuclear ophthalmoplegia. The left medial longitudinal fasciculus is affected. We know this because the motor neurons of the abducens nucleus are still active, but the interneurons are no longer connecting to cranial nerve 3, and this is the site where they would get affected. Now, what happens if both eyes are able to move outward, but neither eye is able to move inward? Well, then we have a similar setup here, except we have bilateral internuclear ophthalmoplegia here. And multiple sclerosis, because it causes expanding, demyelinating plaques that are not in a vascular distribution, can be a key cause of bilateral internuclear ophthalmoplegia, as well as unilateral internuclear ophthalmoplegia as well. And finally, what happens if there's only one movement of the 4 that are possible? And that's we only see the left eye moving outward here. Only its cranial nerve 6 innervation is still intact. Well, in this situation, we have a total abducens nuclear injury plus an extension. It extends out and also affects the medial longitudinal fasciculus on that side. So what happens is these crossing fibers are no longer able to make their decussation and ascend ipsilaterally. The only thing left are these abducens motor nuclei here innervating this preserved lateral rectus, and so that's called 1.5 syndrome, because 1.5 of the 2 total movements, or 3 of the 4 movements, however you want to describe it, are affected here. Pupillary reflex pathologies. So let's walk through the pupillary light reflex pathway. So eye stimulus comes in, hits the retina, and then it innervates via the pretectal olivary nucleus, this Edinger-Westphal nucleus of cranial nerve 3. That's the autonomic visceral motor innervation of cranial nerve 3, pupillary constriction. and we see that it has bilateral innervation. So this pretectal olivary nucleus innervates both the ipsilateral and contralateral Edinger-Westphal nucleus. Then there's innervation from the Edinger-Westphal nuclei out to their respective ciliary ganglia, which then, via these short ciliary nerves, innervate the pupils themselves to cause constriction. So, in a cranial nerve 3 palsy, if cranial nerve 3 causes pupillary constriction, as we can see here, then the pupil is going to be widened. It's going to be dilated because it's unable to constrict. So the sympathetic innervation here causes dilatation, whereas the parasympathetic innervation coming from cranial nerve 3 causes constriction. So how do we further, or how do we localize where this pupillary dilation is coming from? How do we find the failure of pupillary constriction? Well, the first thing we can look for is what's called an Adie's tonic pupil. In an Adie's tonic pupil, there's a ciliary neuropathy or a ganglionopathy. So this portion of the system is aberrant, is abnormal. When this portion is abnormal, then there's going to be hyperreactivity in this sphincter muscle here. So there's going to be super sensitivity to cholinergic agonists. So if we drop acetylcholine agonists if we use drops and we drop it into the pupil here, we're going to see hypersensitivity. So if we use a weak amount of pilocarpine, a weak cholinergic agonist, we're going to see immediate constriction. And if we see that, we know it's an Adie's tonic pupil because there's supersensitivity, because this portion of the pathway is aberrant. If there's no response and the pupil's still dilated, then we know that this isn't the machinery that's upset. If we add a strong cholinergic agonist and we get constriction, then we know we are dealing with a cranial nerve 3 palsy. So somewhere else the injury lies. It's not here, but we do know that it's an oculomotor dysmotility because the pupil's still able to constrict with strong pilocarpine. However, if we still don't get a response, then we know that the problem is in the sphincter muscle itself, i.e. it's been blocked by a muscarinic antagonist, meaning that, for instance, somebody's put atropine drops in and there's just no ability for the eye to constrict, nothing to do with the machinery here, but due to action on the sphincter muscle itself. Now let's talk about a Horner syndrome. So Horner syndrome is pupillary narrowing miosis because of a lack of sympathetic innervation. So there's a couple of key clinical manifestations that you need to know cold. One is ptosis, eyelid droop, and so we can see this narrowing of the palpebral fissure here. We have the pupillary constriction, and then there's also this anhidrosis, this loss of sweating across the face. So there's several key localizations for a Horner syndrome that you need to work through. The first would just be a hypothalamic dysautonomia. A brainstem stroke is a key cause of Horner syndrome. Pancoast tumor, an apical lung tumor, can affect the superior cervical ganglion, which is carrying these sympathetic fibers. And then carotid dissection. With dissection, you get an expansion of the artery, can cause compression compression or just tearing of these sympathetic fibers themselves and causing deactivation of the sympathetic fibers and causing this Horner syndrome. So oral palatal palsies and the gag reflex. So here's the setup, and we'll start with cranial nerve 5, the trigeminal motor. Innervation comes, for instance, from the brain on the left, innervates the right brainstem, which then innervates the motor system on the right, which causes jaw deviation to the left. And then the opposite side causes deviation towards the right, so the jaw protrusion is forward, it's balanced. In cranial nerve 10, we have the same sort of upper motor neuron setup here, except that the motor system, the palate on the right here, causes palatal elevation on that ipsilateral side, and then there's palatal elevation from the other on its ipsilateral side as well. 12 looks a lot more like 5, where the motor system on the right causes deviation to the left, forward and to the left, and then the motor system on the left causes deviation forward and to the right, so they cancel out. In a normal setting, they're balanced, and the tongue protrudes forward. So what happens in these various injuries? So an upper motor neuron lesion on the right here we see, and then here we see a lower motor neuron lesion on the left. Both of these are going to cause the same imbalance and cause deviations in the same direction. Note, however, that there is a minor amount, and there's varying degrees depending on the cranial nerve, of contralateral innervation. So basically there'll be some sparing. So the more severe lesion will come from a lower motor neuron lesion, whereas an upper motor neuron lesion will be less severe because of its contralateral innervation that's causing some sparing. So in both of these instances, upper motor neuron lesion on the right and a lower motor neuron lesion on the left, there's going to be jaw deviation in this direction towards the left. And why is that? Well, because this side that's affected is unable to deviate in the opposite direction, so it's going to point towards the lower motor neuron injury here. In a palatal weakness, there's going to be weakness on that ipsilateral side. So if the left is affected here, then the left palate is going to be unable to elevate. In tongue protrusion and from cranial nerve 12, it's going to look exactly like cranial nerve 5 does, because the spared innervation here is going to cause deviation towards the opposite side. The gag reflex. So in a typical gag reflex, cranial nerve 9 afferents come in, innervate spinal trigeminal nucleus or salivary tract nucleus, and then there's a volley of efferent activation. So cranial nerve 10 via the nucleus ambiguus causes pharyngeal constriction. Motor trigeminal nucleus of cranial nerve 5 causes jaw opening, and then the hypoglossal nucleus of cranial nerve 12 causes tongue thrust. So all of that's involved in the gag reflex. So this is a critical physical exam finding to assess, especially in comatose patients, if you want to look at the integrity of multiple different cranial nerves. So now let's walk through facial nerve innervation, stroke versus Bell's palsy. The key thing about the facial nucleus is that it has both upper and lower divisions. The upper division has bilateral innervation of the forehead, whereas the lower division only has contralateral innervation for smile here. So how this manifests is, in a cerebrocortical stroke, for instance, only the opposite side of the brain is preserved, so it can maintain forehead wrinkle, whereas the contralateral side from the stroke, from the cerebrocortical stroke, is going to cause facial droop here. In a Bell's palsy, either from facial nuclear or facial nerve injury here, none of the innervation to the face is able to be preserved, so both forehead wrinkle and smile are affected. The patient is unable to produce wrinkling of the forehead, and the patient is unable to produce a smile. In a Bell's palsy, there can be multiple different facial nerve innervation features that are impacted depending on where the facial nerve is affected. So if the entirety of it's affected, all of these different features, these autonomic and motor and even sensory features, are going to be affected, whereas the facial nerve, twinges of it or can be just impacted and affect muscles of facial expression without affecting the autonomic component as well. These are the various potential deficits that we can use to help us with localization. And then these are some of the common causes that we need to be aware of. And then there's also these potential affiliated symptoms. So there's this Ramsay-Hunt syndrome, and cranial nerve 8 can be affected. There can be this hearing loss and vertigo with cranial nerve 8 affected. It's also helpful to know that with some of these autoimmune disorders, there can be bilateral facial nerve palsies, which can point to things like sarcoidosis. So lastly, let's walk through cranial nerve 5 sensory, the trigeminal neuralgia. Really all I want to point out is that these different anatomical divisions can really help you localize the fact that you're dealing with a lower motor neuron, cranial nerve 5, trigeminal nerve distribution abnormality, and you can use this pattern to help point towards that localization. Some key things about trigeminal neuralgia itself: it's relapsing and remitting, it's worse with activity, and then when you think about shingles, remember zoster can lie dormant in this cranial nerve 5 ganglion, and there can be vesicular outbreak in these different divisions that you can actually physically, clinically see. So that's a quick walkthrough of cranial neuropathies. Really important clinical information here for localization of neurological disorders.